Hi everyone. Just waiting for people to sign on. Hi everyone. How's everyone doing? Perfect. I'm going to join Carly from Empowered Physical Therapy as well.
Hey, Jessica.
Hi, how are you doing,
I'm
Carly?
great. How are you? Can you hear me okay?
Yes, can you hear me okay?
Yes,
Okay.
perfect.
So I figured let's give people a moment to sign on.
Sure.
How's your day been?
It's good. Tuesdays are a little bit like calmer, which is great. Sun is peeking through. Cannot complain.
Yes.
How
Can't
about you?
complain. Same. I am not complaining at all.
Mm.
So for those of you that are joining us, my name is Jessica. I'm a nurse practitioner with Pelvic Rehabilitation Medicine here in New Jersey. And we have Carly with us from Empowered Pelvic Health. Do you want to introduce yourself, Carly?
Yeah, sure. My name is Carly Gossard. I'm the owner and pelvic floor physical therapist at Empowered Pelvic Health. And we treat anyone with a pelvis. But today we're really delving into, in honor of Endometriosis Awareness Month, endometriosis. And really how to advocate for our patients and also advocate for providers to have this really in the forefront of their mind and on the lookout. Jess, do you want to start with, the symptoms of endometriosis, some of the stats that we have and information? It's just not, as well known about as it should be. So that's, I think, something that we're definitely working on in our community for sure.
Absolutely. So, for those of you that don't know about endometriosis, so the reason why we're talking about it is March is Endometriosis Awareness Month. It is a inflammatory disease that affects many women throughout the world. It affects 1 in 9 women, and it takes 7 to 12 years to kind of get a diagnosis of endometriosis. So you can see there is a significant delay with getting that diagnosis and for proper treatment. It takes about 7 visits to the primary care doctor to be even referred over to a therapist or a specialist for endometriosis. And what ends up happening is that 75% of patients end up getting misdiagnosed. So that's where the awareness needs to happen in all of this. So endometriosis is tissue that's similar that ends up in the uterine lining that appears outside, and it can appear on many different in the pelvic cavity, and it causes issues, and it could start at the first menstruation and it can last longer than menopause altogether. It can affect your bowels, it can affect your bladder, it can affect how pain with intercourse, it can affect different areas, and each patient is going to present differently. And that's kind of the struggle, that there's not one size fits all. And that is why sometimes that misdiagnosis ends up happening.
Yeah.
So,
If we
and
were, if we rewind and think about those statistics, like 1 in 9, like 10% of the population with uteruses, that is like so extensive,
Mhm.
right? And I'm trying to think of any other diagnosis that takes, let's say, on average 10 years to diagnose. Like that doesn't happen. Somebody has a disc herniation, they're getting imaging, they're either getting surgery or they're getting referred to physical therapy right away. And this is like one of the big mystery kind of question marks.
Absolutely. I feel that like there's so much of a delay with it, and I think the in the grand scheme of things, there needs to be more funding and research to women's health altogether that helps supports this. And you probably know this. There's so many pelvic gurus out there right now. Dr. Casperson, Dr. Mary Claire Haven, who's like advocating for enough equal funding for men's health into women's health. So like that's a whole different topic of its own, but I feel like until that happens on a more society level of things, I think it's important for providers like us that do take care of endometriosis to continue advocating to the providers and saying like, hey, this exists, this can happen, this is the signs and symptoms to look out for, this is who you should refer to.
Yeah.
So I think it's on our end of things for right now to kind of help manage that.
And this is one thing too, where I think there's a lot of pros and cons of social media, right? But when I think of, patients and people needing help who are finding, physiatrists like yourself, or they're finding pelvic floor physical therapy, I've had so many patients come to me and they're like, I got to you because of TikTok, because I saw this video, because someone was educating, because someone was talking about endometriosis, because it was March and I was seeing all these posts and yellow ribbons. And I'm like, wow, like I'm bummed that it's not from your provider, but I'm glad that it got to you some way, somehow. So I think that's made a huge impact too,
Yeah.
where
Absolutely.
in whatever matter, patients are and people are getting further education, and hopefully they're going to their doctor and they're like, listen, this has been going on 7, 10, 12 years. Like the math ain't math and something doesn't really make sense. This isn't just my hip pain. This isn't just the fact that I'm leaking. I don't have painful sex just because. We need to dive deeper.
Absolutely. You couldn't have said it any better. I always ask my patients as well. I'm like, well, how'd you hear about us? And they'll always say, like, majority of the patients are saying Google, the website,
Reddit.
Instagram. Yeah, Reddit. Nancy's Nook is a great
Yes.
resource as well. So like everyone is kind of getting their information like more on the media side of things than the old fashioned way of like, hey,
Yeah.
my provider referred me over to you.
Yeah.
So I think, even though that this is a topic for us to educate providers, I always tell my patients, you can be your best advocate and you need to advocate for yourself. So if you feel like the symptoms are not adding up, something's not like everything's not fitting in together, like question it. It's okay to ask, like, I don't get this. Who else can I include in my treatment?
Yeah. So many of them have to be their own advocates, but I think definitely in like the pelvic rehab world, the therapists, the providers, I think it's funny. I joke that I'll talk to a wall about pelvic floor therapy. I'll talk to a wall about pee, poop, and sex. Anyone willing to listen. So even if it's a provider that you wouldn't necessarily think of as working within the pelvis, just for like even just a general practitioner, if they're like, wow, I've never really heard of that, and you just give them like the big 3 or the big 4 symptoms to really look out for, they might be on the lookout. And even if they're not well versed in treating this or don't know enough about it, they're like, you know what, this might be a pelvic floor issue. Let's see if there's providers around. Let's use, Google is really a good resource, and to find more information, to find these providers. But just so it's on their radar. I think a big one too, actually, and a group that I really want to connect with and educate is like school nurses. We think of the misdiagnosis for so many years. And so we have, girls starting their periods when it's like taking them out of school, eventually down the road in their 20s, taking them out of work. And so the sooner we can get ahead of this and diagnose this and raise awareness, even in elementary schools, getting into high school, the better as well.
Yeah, most certainly. I think from my aspect of things, for any providers like seeing and treating patients, the big things to like look out for are that lower abdominal pelvic pain, painful periods, like a long history of it could be, again, just a misnomer. Your menstrual cycle should not cause you any pain. It should not be causing any disturbance whatsoever in your lifestyle. So if somebody tells you that, they're wrong. Painful periods is something that we would want to be looking out for. Bowel, bladder, sexual dysfunction, those are key things. So like with bowel, like if you think about nausea, vomiting, abdominal bloating, diarrhea, constipation, alternating patterns, things along that line that just don't add up to your normal symptoms, like those are things that you want to include. And vague orthopedic concerns like hip pain, SI joint, coccyx pain, like those are all things that you would think like, hey, is this endometriosis in the back of your
Yeah.
mind?
Yeah.
And I'm sure that you have treated patients as well that have had these concerns and you were like, wait, have you been worked up for endometriosis?
Yeah. I had a patient who I saw her. I did not see her preoperatively, if we're going to get into that. But I saw her after her excision procedure, and she was like, I had this chronic left hip pain, and I was convinced I tore my labrum. I was a dancer. I was a gymnast, very flexible. It's possible. She went through the imaging, nothing. She
Mhm.
had her excision procedure, and it was so close to like the descending colon, like sigmoid, that, they removed that tissue, and her hip pain like totally dissolved. Like it was like resolved, I should say. It was like almost immediate. So she had this very vague orthopedic hip pain that was a symptom of the endometrial tissues. So yeah, those are things that we have to look out too. I think of before I specialized in pelvic floor, I worked in orthopedic sports rehab, and it's almost like I wish I knew then what I knew now, but you have to forgive yourself for where you are in like your practice journey. But I remember seeing so many women with chronic low back pain or hip pain, and I didn't know enough, obviously, until my training about pelvic floor therapy. I didn't even take the elective in PT school, not on my radar. And they're not responding to typical treatment. And you're like, wow, you're like scratching your head. You're like, what am I missing?
Mm-hmm.
I got to my first class and I was like, light bulb, this was the missing link the entire time. So even within my scope and my colleagues and friends who are PTs, OTs, to kind of look out for like the vague, you know, coccyx, asking about coccyx pain, SI, low back, hip pain. And if it's not responding orthopedically, to also start thinking pelvic floor, to not be so shy about asking questions about bowel, bladder, sexual function, you know, anything like that, and refer them to, you know, a trusted pelvic colleague.
Yeah, 2 points I want to make based on what you said. So, yeah, the last point that you said that, the patients are really looking for us to be asking the questions. They're not looking for them to just give it. And I had gone to the Ishwish conference and they had brought that up, that the patients want the providers to be asking about this. And so I think from the provider level, we can't shy away from asking about period, painful sex. We have to be upfront with them. This is a natural process. This is things that we're going to have to talk about. So I think it's more ownership on us to be able to discuss these things.
Yeah.
The second thing, school nurses, like that's the age group that you want to be, that girls are starting menstruation. That's where you can kind of like hone in on it. Another aspect is definitely the emergency room. Like if you think about it, women are going in for heavy vaginal bleeding, painful bleeding. Like those are things that we can definitely start seeing a pattern of that you're treating in the ER. Like why are they coming like periodically every month? This is happening cyclically. Like, have you been worked up for endometriosis? At least giving them the information and the right follow-up that, hey, you may want to go see a specialist that focuses on this. I think that's the trend we need to get into.
Yeah, absolutely. So the big ones: bowel, bladder, sexual,
Yeah. Gallbladder,
vague
sexual.
vague chronic orthopedic pain, low back, hip, abdominal for sure, and a cyclical pattern, and
Yeah.
the painful periods, if I didn't throw that in there.
Yeah, of course. And then the other things that they could look out for are like when they're starting menstruation very early. Younger women are more affected by this. So definitely starting menstruation at an earlier age, heavier cycles. Family history is big. If you have any family history of endometriosis, definitely the prevalence of that is there. So we do want to make sure that those women are being screened for properly. Um, Infertility, if you think about it, is another hit. And so I feel like women that are having difficulty getting pregnant and conceiving, those are women that you should be thinking about, like, hey, is this endometriosis as well?
Absolutely. How it can affect like the mobility, maybe at the fallopian tubes or the egg traveling down.
Mhm.
You know, adhesions obviously are near the uterus, so closely related. Absolutely.
Yeah. Another key one for me is that if you notice that your patient's repeatedly asking you for like a doctor's note or an excuse note around the same time, they are missing life. Those are quality years that they're missing. And we need to kind of question, like, hey, what's going on every month around this time? And if it is their period pain, like addressing it that way, like, hey, we need to do a proper workup for this, you know?
Yeah.
I think that's definitely another thing because you are missing life and you
Yeah.
shouldn't be missing life.
Yeah. She may, I bet she's still on here, and I can't say who it is, but I have a lovely patient who I have the honor to work with postoperatively. And that is a huge conversation as well of, hey, I'm afraid to go on this vacation with my husband. It might land on my cycle. Like, what if I'm really in pain? Hey, I'm nervous to go for this, you know, bachelorette party. Same thing. It might land on my period. Like, what if it knocks me out? What about the travel? So yeah, absolutely. There's a very social aspect of this, not just school and work, but like living and fun and kind of like scheduling your life and your weekends around your cycle. It's just too hard to do. So It's a huge quality of life factor.
Is there something from your aspect of treatment that you would recommend for patients that are dealing with endometriosis? Like, how does pelvic floor physical therapy help with the process?
I love this question. In my perfect world, I would have the opportunity to see my patients, obviously post-operatively, but definitely preoperatively as well. There's an amazing resource in book Beating Endo by Iris Orbuck and Amy Stein, and it talks about how this inflammatory disease process, it gets our nervous system really upregulated. When we're upregulated, we're in the sympathetic system. It's like we're running from a bear, right? When we're running from a bear, do we have time to like go pop a squat and have a bowel movement and digest our food? Absolutely not. So the implications for your pelvic floor muscles usually equal tightness and restriction. We think about the close relationship between the abdominal muscles and the pelvic floor muscles. And even just behaviorally, like if we think about how painful it is and how we usually like hug our pain, we need to create space. We want to be as upright as possible. We want our organs, I really think of like bladder, uterus, bowel especially, we want organs to have good mobility, and the abdominal wall to have good mobility, because we know that organs that move well function well.
Mhm.
And we just want to make sure that the pelvic floor works within the system of the entire body, that it can focus on its jobs of sphincter control, of relaxing when you're having a bowel movement, of supporting your organs, and that you have, you're breathing the right way, and that your glutes are supporting you through movement, exercise, and that we're not, in pain. And then likewise, I'm so thankful to have you in pelvic rehab medicine as part of the team, because I know that I don't treat this alone. I never can, and I never will claim that we are able to. So on your end, can you share how you also work with these patients and treat
Yeah,
them?
absolutely. I think you made a great point that you want to be able to treat the patient as a whole. You're not going to just treat one aspect of things and then that be all, you know. This has been going on for quite some time for most patients that are ending up to us. So there's always some central activity that's going down, and calming down the central nervous system is a big part of it as well. So whatever treatment that I recommend from my end, I'm always using multiple disciplinaries. It's never just one piece is going to solve everything. So for somebody who's coming in with endometriosis, I think for any provider that's seeing patients, it's always to recommend them to somebody who can take care of the endometriosis. So preferably an endoexcision surgeon that can go in, explore the pelvic cavity and see where the endometriosis is. Going in will help them visualize if there is any deeper endometriosis, lesions to be sent out, and that will be the true diagnosis and treatment of the endometriosis itself. Starting with that, usually we're a physiatry-based office. We're focused on the muscles and the nerves of the pelvic floor. So if a person comes in for endometriosis-like symptoms, we're usually doing what's called like that prehabbing that you talked about before, as well as rehabbing. We're trying to get their pelvic floor into space for surgery, and then treating them for surgery, and then coming back to us for the rehabilitation portion of it. So we treat the muscles and the nerves with what our PRM protocol is, a combination of of nerve blocks and trigger point injections. What they do is that they take this upregulated muscles and nerves that are tight and constricted and relaxes the pelvic floor. The way that we describe it in the office is you're taking a pelvis that's in New York City out to Colorado where they have enough room to graze. So that's, everyone gets a kick out of it when I describe it that way. And so it's very similar. So it's tight, congested, it's aggressed, it's pissed off. You want to get it to open land where they can breathe and function properly. And so that's what the combination of the treatment does. And I always tell people that the injection part of it is just one piece of it, inclusion of a pelvic floor physical therapist that can help with rehabilitation, along with a therapist that can help cognitively as well for you, because these symptoms are happening on our central nervous system and you want to calm it down. Things like mindful meditation, yoga, journaling, breathing exercises. These are all things that kind of down train the nervous system. So that is one component of it. Managing symptoms pain wise is another component of it. And so you want to do these things together to have an optimal result with it.
Absolutely.
So I always tell people there's never just one treatment. You want to treat from all aspects,
Yeah.
and when you do that, you're going to get a better outcome from it. So
You
I think that's for the non-surgical aspect of things that you can do for endometriosis.
Sure. It's so funny. You say the New York City, your pelvis is in New York City. When people come in here, we talk about like breathing from your diaphragm and having space, you know, and movement of your rib cage. And when I explain apical breathing, right, and your neck's all tight, your jaw's all tight, I'm like, this is the tri-state area breath. We need to go chill at the beach. We need a pina colada in our hand. We're chilling. There's no threat to
Absolutely.
the body. So the tri-state area in New York City, I love that analogy. But yeah, we do, like, as you know, specialists in this field, we know that it's a team effort. It's like the alley-oop, right? We need the excision specialist who treats by removing these tissues, right? Driving these symptoms in the first place, or part of it. The physiatry aspect of it is of treating these muscles and nerves via your protocol. Mental health therapy to work on, you know, mind body awareness and you know, maybe mindful meditation, or just processing the fact that their symptoms were neglected for a decade. That's something to really process and work through as well, you know. And then from our aspect, really just the neuromuscular system as well, gaining awareness of this area and just kind of like retraining these muscles to work with you, kind of not causing any more issues. You wrote down, and this is the best, like, I think the overwhelming theme in treating endometriosis, or patients with endometriosis, I should say, is like validation.
That's key. Honestly speaking, I feel like when patients are having seen 7 to 12 providers, been misdiagnosed, being told that it's in your head, drink a glass of wine, have a baby. I'm like, no, that's not what you really need to do. And so I think validating that, like, what you're feeling, you're not alone. We're here to help you. We're going to go through this step by step. And I think just hearing them puts people at ease. And it's kind of foreign sometimes too, you know, they're receiving this level of service, this medical treatment from us, and they're like, they've never received that before. And I just hope that, like, any provider watching this today, that you, when patients are coming to you, don't tell them it's in their head. Don't tell them to drink a glass of wine. Express to them that, hey, this is going on. I may not have all the answers for you. I think your patients would appreciate you more being told that you don't have the answer for it, but you're going to refer them to somebody else that will. And I think when you do that, I think you build a better connection with your patients as well.
Totally. Yeah, it's sometimes seeing you or seeing me, whoever, you know, they find first. How often do you hear, like, I had no idea that this was a thing? If I
Absolutely.
had a
All day. All day.
nickel, I had a
All
nickel for
day.
every time I heard, I didn't even realize this was a thing. And I'm like, oh, just wait, we're gonna really blow your mind. Like, they come in here and they're like, I've been to all these doctors, I don't have any answers, nothing's helping, nothing makes sense. And we're like, I think it might be this. And we actually see this very frequently. And I want you to see my friend Jessica. I want you to go to the specialist here. And let's investigate further, because there is something going on. Like, they're not in your head, just like you said. Validate those symptoms.
Absolutely. And to touch on the surgical aspect of things, like surgery, yes, you want to take out the disease portion of it, but that's not going to be the end piece of it. This is a chronic condition. So that's kind of where we come in and we tell the patients, like, hey, you know, those muscles and the nerves, they're still left treated, and we do need to take care of that. So that rehabilitation portion of it, I think, is key in all of this.
Yeah.
And awesome.
100%.
Does any of you maybe take some questions?
Yeah. Anything going on over there, guys?
So,
And if not, that's okay. But
yeah,
we really covered a lot of it.
absolutely. I feel like it's definitely a bigger picture than for us, but I think one thing our practice does do, I think all of our providers do, anytime we do get any provider referrals or we're getting a name of a provider that, you know, patients have gone to quite frequently and having gone a little bit in, they've gone in circles. So that's when we reach out to them and tell them, like, hey, we are pelvic rehabilitation medicine. This is what we do. This is how we can help patients. And once we raise that awareness as to, like, what is going on, I think the community also has a resource as well. Like, hey, I can't treat this, but I can refer you over. And I've had so many patients come over that way, just based on a mutual phone call of, like, hey, you're treating so-and-so, this is what we do. So I feel like getting the conversation piece started is a big thing.
And let's say somebody got to me like, I want to send their information and I want to have, even if I don't get that much back from them and they might not be on our specific treatment team. I was working with someone and she was like, wow, you know what? I told my GP about you and about, you know, what I discovered from you referring me out. And they were so receptive and they were really wonderful. We went in there, we discussed about it, about a lot of different pelvic floor, you know, dysfunctions. And they were like shocked. They were like, we hear these complaints all the time and we never know what to do or who to refer them out to. So, you know, not for lack of trying, but for just lack of knowing. So even, just communicating with these providers, no matter where in the team they do exist, but somebody that this you know, patient is working with, and you'd be surprised like who comes back and they're like, wow, like I'm really going to screen for endometriosis. Let's look for those like big 4 or 5 symptoms. I'm really going to screen for pelvic floor dysfunction. Like give me a Cosine pelvic floor dysfunction screening tool that we can have at the office. And it really changes the game for a lot of people.
Yeah. Someone left a comment for us.
Yes.
Pelvic rehab. You guys should go to middle schools and high schools to talk to the students. We would love that, honestly.
100%.
I was actually speaking with Dr. Shikande, who's our founder of our practice, and expressing to her that like when I went to Rutgers for school, and then we had such a small topic on endometriosis that we weren't like trained to like talk about this all day long. So like I feel like a good give back would be to go back to Rutgers nurse practitioner stuff and talk to them that, hey, endometriosis can present like this is what we can do, and informing our providers that are going to be futurely treating. I think that would be beneficial. So I think we should add this one to the list as well.
And even talking to like nurse practitioner programs or different like medical programs, saying like, hey, this is a specialty and it's a really important one and we actually need a lot more of us. That's how I feel about, you know, pelvic therapy, whether it be physical therapy, occupational therapist. It's when both of our scopes. And when I am a teaching assistant, I'm like, guys, like who's in Jersey? Like we need more of us, believe it or not. Like we need more.
Absolutely. I think just getting the word out is the first way we could start.
Yeah. Laura, set it up. You're hired. Okay.
Absolutely.
Yes, clearly left. Please discuss. Can you speak on this, Jessica? Please discuss trapped gas in the pelvis. We had a question from.
Awesome. Okay. Trap gas, honestly, it all depends on where it's stemming from altogether. So I think having an evaluation done and seeing if it's more, if it's more GI related that you're experiencing that, and pattern wise, just understanding what's triggering it. I think that would be the first place to start, understanding what's causing it and what's treating it.
Yeah. I love, we all produce gas. I think it's around like 1,500 cc's a day. So people stop holding in your gas, let it out. Number one. Number two, also sometimes going through a nice bowel diary of like what's coming in and out every day, and seeing if there's like an excess of gas producing foods or even like individual triggers for you possibly. Excuse me. So I hope that helped. Awesome.
This has been great, Carly. Thank you so much for treating our pelvic community. Thank you for being our advocate. Thank you for being there for us and our patients as well.
Yes, you as well. I'm going to touch on this one more time. Clearly, Lux, it also can be mechanical, meaning in order to allow gas to exit or stool to exit, I really think of 2 muscle groups. One is deep in the pelvis and one is literally your anal sphincter that you can really see. We have to have the coordination of these muscles to relax and open up for either one to exit. So sometimes it's a coordination of these muscles. It's very intuitive to holding gas. Like I joke with everyone, I'm like, it's very intuitive to holding gas. Like imagine like you're on a crowded elevator on like a first date or something. It's not always super intuitive to let it go.
Absolutely. We have Britannia saying that I really struggle with trap gas too. I have to lay down and stretch my whole body to get it moving.
Yeah.
So that's great.
Yeah, you hit the nail on the head. Dysenergic. So dysenergic just means that the muscles are kind of doing the opposite of what they need to do. We see this. I just saw this morning. We see this every single day. And like I said, it's not something that's so intuitive. Reviewing treatment processes for pelvic floor pain, especially as related to endometriosis. We discussed how we want to really be multimodal and treat the entire person from a psychosocial aspect. So maybe finding like a mental health therapist, physical therapy, physiatry. We discuss down training the central nervous system, treating the muscles and nerves of the pelvis. And then if we are suspecting endometriosis, referring to an excision specialist for that procedure as it is the gold standard.
Yeah, and for the PRM protocol that we do at our office, it's a combination of muscle nerve blocks and trigger point injections to calm and relax that pelvic floor. We're again taking them out of that tight congested area and giving them the room that they need to breathe and function properly. It's about retraining and resetting your pelvic floor. It's not just a symptomatic treatment. We're trying to regain the mobility of that space as well. So I always tell patients, as cliche as it sounds, it's not a Band-Aid approach. We're not looking for you to feel immediate effects from it, especially if you've been dealing with it chronically for a couple years now. So it is something that takes some time, but it's trying to retrain your pelvic floor to be in the space that it needs to be to properly function.
Yeah. And to touch on that, it is something that takes time. Like we know neuromuscular change really occurs in like the first 12 weeks. And so being a part of that team also means being patient with your patient, meaning that, progress, not ironic, but, we can kind of be tired of hearing it, but progress very rarely looks like this, right? We have a really good day. We might have a little dip, depending on what we're progressing or our activity. So really just being kind of like a partner in rehabilitation as far as that's concerned, because this is a journey together for sure. This is not
Absolutely.
an ACL repair. This is not a knee replacement. This is really involved. And right, like we keep hitting on multimodal. So we have to think of the entire person and how long this is going on, and how long it's kind of gone diagnosed as well.
And another thing is that why treat it with just one thing when you have all these different layers? And so it's important to go in there with all the tools that you have possible to treat it rather than just one.
Yeah. So we have a resource on pelvicrehabilitation.com. You can look at the PRM protocol for more information. And then also if you're suspecting neuromuscular deficits, or if you think that you may benefit from pelvic floor therapy, you can find a pelvic floor physical or occupational therapist near you at www.pelvicrehab.com. That's the directory through the Herman and Wallace Institute. And then there's also one through the APTA on the Women's Health chapter. There are more, but those are the two big ones. So if you think that, you could benefit from either one of those, find someone near you.
Absolutely.
Cool.
This has been great, Carly. Thank you so much for taking out the time today. I hope our patients appreciate all of this. We appreciate you. Thank you for including us in your treatment as well.
Awesome. Thank you so much, Jessica. I appreciate you and PRM and everything that you do for our patients. And I really thank you for your time today too. This has been great.
Awesome. Thank you guys.
Bye, everyone.